Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome everyone. My name is Renee Garrett and I am your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Dr. Kristin Koch is the owner of Evolution Hearing. She is also an adjunct faculty member at James Madison University. Dr. Koch receives an honorarium from SpeechTherapyPD.com for participating in this podcast episode. She has no relevant non-financial relationships to disclose. I'm a paid employee of a private consulting firm in the Commonwealth of Virginia, and I'm also the host of this podcast as well as other webinars on SpeechTherapyPD.com where I do receive financial compensation. I am currently the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Dr. Kristin Koch, AUD, owner and audiologist, who received her doctoral degree in audiology from A.T. Still University in 2012. She was awarded her bachelor's and master's degrees from Western Michigan University. She's a member of the Academy of Doctors of Audiology, or ADA, the Audiology Practice Standards Organization, APSO, and also serves as a preceptor for audiology doctoral students. Dr. Koch is an adjunct faculty member at James Madison University, teaching their audiology business course to doctoral candidates. She served as Vice President for Audiology on the Speech Language Hearing Association of Virginia, SHAV, board from 2021 to 2024. After working with ear, nose, and throat physicians in the Culpeper area for many years, she made the decision to open her own independent private practice in Charlottesville in 2012. She's been very active in the community, including the Chamber of Commerce and local elder care professionals groups. Dr. Koch and her husband, Drew, grew up in Michigan and spent time living in Columbia, South Carolina, and moved to Charlottesville in 2005. Dr. Koch's husband is the Associate Director of Bands at the University of Virginia. They are both active in the community and on grounds at UVA. Their two children, dogs, and a small flock of chickens keep them busy at home. Dr. Koch enjoys properly fitting people with hearing loss by following best practices, including the most thorough testing procedures and different verification tools, including real ear measurements. A person's hearing loss is often noticed by those people around the patient on a day-to-day basis. She greatly appreciates it when patients involve their spouses, family member, and or friends in the process. The whole experience is enriched tremendously when approached using a team philosophy. Dr. Cook has received the Best Bedside Manner Award in Audiology from Our Health magazine for many years, Charlottesville's finest for both local audiologists and hearing aid center, along with other awards as an audiologist and practice owner of Evolution Hearing. So nice to see you, Kristin.
Thank you for the introduction.
Of course. No, when I first read through it and I saw two children dogs, and I almost said a flock of children, and then I realized I'm glad I went through it beforehand, because a flock of children would have sounded a little bit strange.
Yeah. We do it.
Yeah, thank you for being here. So can we kind of just talk about like the role of audiologist and how, like, just to kind of start and warm up about how audiologists and SLPs sort of work together, and I guess in the most generic of terms, I guess, if that makes sense.
Yeah, so I thought I wanted to do speech pathology when I was in grad school, but the math and science kind of appealed to me, and I've always been kind of a gadget girl, and it's very heavy technology in audiology, it seems like, because the focus does tend to be hearing aids. But I've always been pretty passionate about, looking at people as a whole person instead of just focused on, the ear or hearing loss or tinnitus. And I think sometimes we get too far in the weeds in our professions and specialties. So it is nice, and I will say that participating in our state association with SHAV kind of also opened up my eyes to the fact that there's a lot of us and we can all support one another by working together instead of just being so specialized in our individual professions.
Yeah, and I think one of the things that really it is something that I talked to you about, and I've been looking for since I started the podcast, was to find an audiologist who was a little bit more mindful of looking at the connection between cognition and hearing loss, because we've been hearing, I mean, we've known for a long time, the research has proven that that's a thing, but to hear it more now in different media outlets and certainly in social media, to see that more in the forefront is helpful. But it's also, I think, for those people who don't know, I think it's a little bit confusing or maybe a little bit off-putting. So
yeah, I think sometimes it can be used to scare people into doing something, whether that's purchasing hearing aids or, rushing to the physician to assume you're going to have this dementia diagnosis and all of that. But I kind of frame my understanding and the way I talk to my patients about it as a listening effort and listening fatigue, and then, the cognitive decline that could potentially come from all of that. But I'm grateful that the media and, podcasters like you, I mean, like, every little bit can help spread the word. And at this point, I think there's a mountain of evidence, and it's not like a 1 or 2 off research study kind of thing anymore. I mean, there's no denying that there's some kind of link between untreated hearing loss and a higher likelihood of cognitive decline. I mean, I'm looking forward to more and more research to tell us the why about all of that. But when you think about listening effort, to me, it makes a lot of sense.
yeah, and then we have all of those other things that can happen that we know kind of contribute to this cognitive decline. And it can also be a connection to hearing loss, things like TBI, traumatic brain injury, alcohol use disorder, obesity, and
Smoking.
yeah, a lot of things like obesity and heart disease, substance use kind of roll into a lot of other diagnoses, cardiovascular disease, which, is another precursor for sometimes diabetes, which is another risk factor for stroke. And so I think when we connect those pieces, it's helpful to look at what is the underlying component there that's connecting all this, because we've got these things that we can't change, and then we've got these lifestyle things that we can change. So what are some of the things that are modifiable for the average everyday person that maybe reduce their risk future cognitive decline and hearing loss?
There's been a lot of research about that, like specific articles in the Lancet journal and things through the years, but untreated hearing loss, and specifically in midlife, is one of the most modifiable risk factors for dementia later in life. But you do have TBI in there, and obesity, and alcohol consumption, and lack of education or less education, social isolation, and other risk factors. So we know the vast majority of cognitive decline is out of our control. But when it comes to modifiable risk factors, for the longest time, untreated hearing loss has been pretty much the top or in the very top of those categories.
So are there things for untreated hearing loss? Are there risk factors, or are there markers or milestones that we need to be looking for as far as SLPs to make that appropriate referral?
I think when someone mentions, hearing difficulty, or I can hear but I can't understand, or I struggle in background noise, and I mean, we all kind of laugh it off and say, like restaurants are really loud nowadays, and even I have a hard time, and oh, you're just getting older. But no amount of hearing trouble is normal as we age. Same with cognitive decline, like that is not normal to have happen as you get older. And so any of the typical signs of hearing loss should be a red flag for referral to an audiologist.
Yeah, no, I think that's great. And I think, touching on less education, social determinants of health, I talked about this. I did a guest lecture at JMU on Friday for both students and the community. And I was kind of surprised at a lot of people that were in attendance who had not heard of social determinants of health, meaning, less education, access to food, access to quality care. And I won't go into like all of that, but just how that becomes cyclical for people's care in other realms, not just their care with their PCP, or not just care because that now they've had a stroke, or dental care, or whatever it is. It becomes cyclical because there's some mistrust in the medical community for marginalized groups, and then there's also poor access to care, underinsured or uninsured people who, I would say even when I started practicing as an SLP, I don't think most health insurances really did a good job saying you have coverage to go see an audiologist. They might have said you have coverage to have your PCP tell you that you're not hearing as well because your husband said, or your wife said, or your granddaughter said, that that they know you can hear them, but you can't discriminate what the speech sounds are that they're saying. They can't discriminate speech and noise, like you mentioned. And I think there's been this evolution in the past 10 years for sure on that. But, what are some of those efforts, sort of advocacy efforts, or ways that you have seen your practice modify from when you worked for someone else to now having your private practice for the last few years?
It's been a big evolution, which is why I named my office Evolution Hearing, because things are constantly evolving and I wanted to be part of that, right? I was working for ENT physicians up in Culpeper, and they were great physicians, but the office was run as the ENT doctor's office, and I was the girl in the back doing the hearing testing, and they dropped the chart in the door, whether I had, 5 patients behind them, or, didn't have a hearing test for 4 hours. And so it was odd. And I wanted to give my patients a better experience, have more time, have a schedule that made sense for both productivity, but the patient experience. But honestly, I mean, things have changed a lot since I opened the office 12 years ago. I started and kind of was told that hearing aids and hearing testing was a more retail medical purchase, and that I should do hearing testing at no charge, so I didn't have to participate with any insurance at all. And I could make my money from selling hearing aids, right? I mean, that was a very traditional way of doing things for the longest time. However, and thankfully, this is even after the AUD came out. So I would like to say that obtaining a doctoral degree, like made me a different professional, but it didn't in some respects. So this is all like after, within the last 5 or 8 years, I would say, things have changed a lot. And finally, audiologists and I would say all medical professionals are kind of finally standing up for ourselves and saying, like, I have a lot of knowledge and training, and all of that is worth something, and I'm not going to give my services away. So then I started working with health insurance companies and filing the claims and getting paid minimally, but at least something through the health insurance companies. But then a couple of years ago, I really changed and I went all in on charging for my services, itemizing my services, and providing additional testing that's not recognized by health insurance companies yet. And that includes speech testing and background noise, uncomfortable loudness level testing, because some people can become sensitive to louder sounds, and we can document that and determine their range for comfortable sound levels, and also this cognitive screening piece. So now patients come in, the hearing testing that's recognized by insurance is billed, and then on top of that, they pay an out-of-pocket fee for their initial appointment, and we are busier than ever, both with just patients coming in because they've heard about us and our reputation, but also tons of physician referrals. So it seems to really be resonating with patients and physicians when you talk about all of this the way I have been, which is mainly like listening effort. You shouldn't have to work as hard. Things could be more effortless to hear and understand, and you can use that brain power for other things like storing what you heard into memory.
Yeah, and I think that's really powerful because again, you're looking at the holistic version of the patient, which is the patient, right? That's who they are. And I can remember when my mother-in-law, who, I mean, people, if they listen, they hear me talk about her quite a bit because she did have a diagnosis of Alzheimer's disease, but she, before that diagnosis, had significant hearing loss. And when she went for actual formal testing, it was deemed sensory neural hearing loss. And so I kept saying to her, why do you keep spending $6,000, $7,000, $8,000 on hearing aids? Because they don't work for you. Like, they weren't helping her, because she would wind up buying the little listening ears off of Costco or home shopping. She was a big QVC fan. And she had the TV ears and these things that would help for small little things like that. But for her, she could have $8,000 worth of hearing aids, and she still couldn't hear us at a conversation at a holiday when there's 20 people in the room. She could hear the noise, but she couldn't speech discriminate, what we were talking about. So it was interesting because she felt like her experience with the audiologist was, she termed it cold, but when she went to Beltone at Costco, they listened to her. That's what she would say.
Because they were probably getting her all excited about, potentially purchasing new hearing aids. Now,
exactly.
I mean, most people have sensory neural hearing loss. That is a permanent type hearing loss. Tends to happen as people get older, and like, if it's not ear infections and all of that with a conductive type medical hearing loss, it does tend to be sensory neural, permanent. It's not going to get better. But within that big spectrum of people who have sensory neural hearing loss, people can have a very good ability to hear and understand and discriminate between the sound. And then there's people who really, really struggle. And that's a big factor when people really struggle, even in quiet, to discriminate between speech sounds. That tends to be when hearing aids don't help. And potentially, other options could be discussed, such as a cochlear implant, or maybe some kind of, more basic pocket talker just when people visit. I mean, there's different things that could be done. But most people are somewhere in the middle, and most people complain about how they can hear, but they can't understand, because most people lose the higher pitches first. So that, like, you can still hear, but the clarity is lacking, and it's just not as sharp as it used to be. And most people also struggle more when it's noisy, because they can hear those lower pitch bass sounds much better than they can hear the higher pitches. So they pick up all the background noise, but they're not getting the voices and the clarity for understanding what people are saying. Now, in the past, we've kind of ignored all of those concerns and done a basic hearing test where you press the button when you hear the beep and you repeat words back in quiet. That doesn't really tell us, like, it tells us something, and I don't want to be disrespectful. I mean, that's still what we do, like, all day, every day. But on top of that, there's some additional testing that can be done, specifically like speech and noise testing. Like, throw in some background noise and let's give a patient a more realistic test environment. And now we can actually document how much or how little they struggle in background noise. And then it's like, oh, no wonder this person, falls asleep at the dinner table or in a restaurant, because they can't, they're struggling so much that it's just easier for them to zone out, and then they do end up falling asleep. Or someone who does really well in noise, and it's like, okay, well, no wonder you've been able to get by for years. I mean, you do have a good ability to understand even in background noise. So now we've got some additional documentation and evidence and outcomes that we can measure. Unfortunately, most offices don't still test for that, but I feel like we're finally headed in the right direction, and that's kind of picking up steam within the audiology community.
Yeah, and it's interesting because, you think about not just the fatigue part of trying to understand and the speech and all this noise and different environments, but thinking about the cognitive load that also increases, because you're straining to hear, but you're also straining to interpret and comprehend what was said, which is a whole different piece, right?
Yeah, and by the time someone's figured, that particular word or sentence out, typically, things have already moved on and they're talking about something else. So, like, you're constantly behind the 8 ball, and then it's just easier to zone out, and that, leads to the social isolation and the social withdrawal, which is another huge risk factor for cognitive decline. And, it's all together.
Yeah, and I think when we sort of think about this more for, like you said, the across the lifespan, when patients sort of move into that middle-aged to geriatric realm, and they're experiencing things like loss of loved ones, loss of siblings, loss of even their spouse. And so that social isolation piece and the depression piece becomes even more prevalent because of these extraneous factors that they don't have any control over. And so it does, I think, and we saw this with the pandemic, right? Because a lot of us were socially isolated, and it just became easier sometimes and for some people not to participate. And I know I've kind of been guilty about this, because sometimes I'll find myself now when I'm in more social situations where I'm like not necessarily paying attention, which is terrible. I sound like a terrible person, but that's what happens.
The same kind of thing can happen, like, even with people you're around, their voices are familiar and stuff, and you leave a restaurant and you're like, oh my God, I'm like wiped out, right? I mean, that happens to me all the time, and I'm in my 40s. So, hopefully when I'm twice my age, I'm like, I can't imagine what that's gonna be like.
Or even,
More research about, like starting sooner with hearing aids rather than waiting until later and continuing to make it more effortless to participate and understand and communicate and things.
well, and I think for those of us who are parents too, you get good at, especially if you have more than one kiddo at home, it's like you sort of zone out sometimes or tune it out, which
Yeah.
is terrible, but I think it's valid. I think we all do it.
I think I'm able to multitask. And so I'm like checking my email or looking at my phone, and the kids are trying to get me to pay attention. And I think I'm paying attention, but I'm like, oh, sorry, what'd you say? Like you can't. And there are some people, it's not just about getting older, right? There are some people who are much younger who come in and say, I have always struggled in noise. Or, you've got the kids in school who are misbehaving and kind of tuned out, and it's like, is something else going on? Because, it seems to take a lot of effort to participate and stay on top of the conversation.
Yeah, it's definitely interesting. And I'm like you, I like to see the research and how that evolves just in the last couple of years with all these kind of unique things that have kind of been out there. So really, I'm looking at this study that you sent over with Glick and Sharma from January 2021 about treatment with hearing aids and improving neurocognitive function in something like an age-related hearing loss. Is there something with that you can kind of talk about with neuroplasticity?
I mean, now there's more and more studies, and with all the scans, and that one specifically measured like EEGs, and it's documented now what happens, and you can see the areas of the brain light up that are outside of the auditory cortex when people are trying to follow speech and with hearing trouble. And then, months later, after they've worn hearing aids for a period of time, you can see the areas of the brain light up, but they're now all back in that auditory cortex where they belong. Like the area of the brain responsible for the hearing is doing the hearing. And when they're not wearing hearing aids and not getting that auditory stimulation that the brain is seeking, there are other areas of the brain that kind of step in and fill in the gaps, but it shouldn't be like that. And so I think with more and more research and things that we can prove, hopefully we can take this information to, Medicare, Medicaid, these health insurance companies, and say, look, yes, hearing aids are expensive. They're expensive for us to purchase. They're expensive for patients to purchase. I hate it, but it is what it is, right? And Medicare, if you would cover the cost of hearing aids, here's all the research that tells us that in the long run, you're going to end up saving a ton of money because of all these connections and all this research and, things that could be prevented downstream.
Yeah, imagine that if we listen to the people who are professionals and not just analysts of the data. What a different world.
Yeah, I mean, patients who had Medicare up until very recently still had to get a referral from their physician just to have their hearing tested.
Mm-hmm.
So no wonder people are going to, Miracle Ear and Costco and, hearing aid dispensers. No offense to them, but there was a barrier for people to come see audiologists. And finally that has been lifted, and for the most part, people with Medicare can come see an audiologist without a referral at this point. But we still have a lot of work to do.
Yeah. So let's run through, just before you started doing the cognitive screening in your practice as part of what your evaluation looks like. What was a typical, or was there a typical sort of process that you went through for an evaluation for someone who came in and just said, hey, my spouse noticed I can't hear them as well, and I'm here for you to check my hearing out. What would that look like?
Typically, threshold testing for pure tones, so the press the button when you hear the beep kind of thing for lower pitches to higher pitches, right? The speech sounds in both ears. And then we would do it's called a speech reception threshold, where you're kind of like just double checking those pure tone thresholds with a speech understanding ability. And then you're making the volume louder and giving them words in quiet. And it's like, yep, sure enough, you've got hearing trouble. That's permanent, right? It's not going to get any better. But that's pretty much all we did. And we said, hearing aids are the solution to this hearing loss. And, please consider spending $2,000 to $7,000 for a set of hearing aids. And by the way, insurance doesn't help with the cost of that. And that's what I would say most audiology and hearing aid dispenser clinics, that's still the typical protocol.
Are you taking advantage of our new amazing feature? The certificate tracker. The free CE tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider, speechtherapypd.com.
So what really prompted you to incorporate this cognitive screening?
It was being talked about, and there was more and more research, and I would say I added speech and noise testing first, and this just kind of made sense as like one additional service we could offer our patients. I will credit one of my patients many years ago who kind of embarrassingly, he said jokingly, and he kind of was blushing, he was like, I'm kind of squinting with my ears to hear.
I love that. I mean, I don't love it for him, but I love the way that was described.
Well, yeah, so it kind of like blew my mind. And I said, do you mind if I use that term? Because that's exactly a great way to describe it. You can hear, you can get by, but you're working harder than you need to work, and things could be more effortless. I say that like all the time in the office. And once you started using those, phrases and things, you just started seeing patients light up and saying like, you seem to really understand this. Like, that's it, you get it. I can hear, but I can't understand. Having more trouble in background noise. I'm working harder. So this just seemed like a good logical step to say, this is one additional test we're gonna, not test, I say we're gonna do a quick screening, because there's more and more evidence about the link between untreated hearing loss and cognitive decline and cognitive load. Let's do this quick screening. And the vast majority of patients are very, I wouldn't say excited, but like they're all for it and want to do it. There are a few of our patients who have kind of pushed back and have not wanted to do it, and that's okay. I also don't do cognitive screenings on patients who have already been diagnosed with dementia. That isn't going to give me any more information. We already know there's an official diagnosis. And so, every appointment, shouldn't say every appointment, but some appointments are slightly different than others, depending on what I feel is appropriate for that particular patient.
So is there something like a cognitive screener in particular? One of the participants is asking if there's a name of the cognitive screening that you use.
Yeah, so I'm using a computerized screener called the Cognition. They have a couple different variations, one for physicians specifically, and this Cognition Thrive is what I'm using, and that's been designed for audiologists. I will say that there's been a lot of talk about cognitive screenings and whether that's appropriate for the scope of practice as audiologists. And our national academies have given guidance that yes, it is in our scope of practice because it's a screening. We're not doing, diagnosing. I'm not a physician. I'm not a neurologist. I'm not an expert when it comes to brain function, but this is a screening that can provide additional information and kind of support the patient's journey at our offices. And the physicians I've been working with have been very supportive.
What are you able to share, like some of the types of questions that are asked on that, or is that more of like a proprietary thing that you can't say?
I don't believe they would mind me talking about it. So there's 6 individual, think of them like brain teaser activities. It doesn't have anything to do with hearing, and it actually takes hearing out of it. So there is an audible instruction for the task, but there's also the visual instructions for the task, and there's practice rounds. So the tests vary. Patients have to, so it's only a wheel. There's no keyboard, there's no pen and paper. So they take a lot of variables out of it, which is one of the reasons I like it. So they're basically like spinning a wheel to answer the questions.
Okay. So from a motor standpoint, say you had a patient who maybe had a TBI or a stroke in the past and maybe have some like upper extremity weakness or fine motor like discoordination, then that wouldn't necessarily be an issue.
Not necessarily. There have been some patients who have had tremor or maybe such vision difficulties that we've decided not to do it. We do have the pen and paper, like MOCA cognitive screenings in the office that we could use as a replacement. So, it's nice to have options. But this one on the computer, there's a circle with brighter dots that they have to follow with this wheel, and the brightness becomes dimmer and dimmer, so it's harder and harder to follow the lights. And the wheel feels like it's moving too quickly or not quickly enough, and that's all part of it to make it more challenging. I have to identify a word from nonsense words. I have to remember and identify the first word that pops up in a short series of words. So it might flash dog, man, he, and you have to find the first word as quickly as you can. And those images, the words get grainier and grainier and harder to see. And then the hardest one is probably that same kind of thing with shapes. They're unusual shapes, and those shapes get harder and harder to see. So all in all, it takes about 5 minutes. That's pretty quick. And as patients do well, it changes and gets more tricky in each task. Or if they're not doing well, it gets easier. So it's changing as the patient does the actual testing.
Okay, so it's responsive to based on their response time so that's really good because it's looking at response latency, but it's also looking at correctness. So you're it's sort of like a duality.
Yep, it generates a report and gives us 5 different areas. Processing speed and reaction time are 2 of those. And then there's a memory parameter, visual spatial, and then a higher level like executive function. So you kind of can put that all together and talk about how, like our ears pick up the sound, but it's your brain that sorts the voice through the background noise, or shifts your attention from one person to another. Like that actually happens within the brain.
Right.
And when people stop and think about that, they're like, oh yeah, like now that you say that, that makes sense. And that, like, yeah, that's what happens. But in the moment, like sometimes we're so focused on the ears and hearing, we make it all about their hearing in the ears. Like, well, you know, it's a lot more complicated than that.
Well, and I think the flip side is true for speech pathologists, because we tend to go behind other, especially depending on your work setting, but particularly like for me working in acute care for so long, you know, a lot of times I'd have to go behind nurses or physicians or go with them and say, hey, you know, Mr. So-and-so has a hearing loss. Either he doesn't have hearing aids or he does, and make sure he has them in, because he's going to say yes to everything you say. And it was surprising, I think, when I was less seasoned, like newer clinician, to find out that people just didn't know. They weren't trained in the way that we are trained and the way that audiologists are trained to sort of be mindful of that and look out for those adaptive equipment, because that's really what hearing aids and glasses are adaptive equipment. Dentures are adaptive equipment. We don't necessarily in the general population think of it in those terms, but when you do, and you make sure that the person has the tools that they need in order to set them up for success, it's astounding that they're able to perform in a way that's completely different than if you went in, woke them up in acute care, they've got an illness or a new diagnosis of a disease, and they don't have their hearing aids in or their glasses on, and they can't hear you or see you. It's off-putting. I mean, it's off-putting for me. I was in the hospital back in May, and I was kind of grateful that they didn't ask me what day it was, because quite frankly, I've always said this to my patients, I would have had to look at my phone because they weren't updating the whiteboard in my room the way that they were supposed to. So if they had woken me up at 4 a.m. and said, what's today's date or what's today? I'd been like, I don't know. Why are you asking me?
But yet, if a patient had, you know, like an amputation or really thick glasses or something, I mean, it's pretty easy to say, well, this person needs some accommodations and, you know, you need to work around this. But yet, hearing loss is so invisible and often overlooked, and, you know, people are quick to think, you know, like, oh, this patient has dementia or is totally out of it, you know, not responsive. And it's like, just put their hearing aids in their ears, you know, like this is a thing.
Right.
They need to hear that.
I think for me, I had a really great, in undergrad and graduate, it was the same person that I had for audiology, but they were really great at kind of explaining those scenarios when I was still a student. And so when I took years ago, when I took a PRN gig working in an assisted living facility, that was sort of one of the things that I'd get these referrals, because Mr. So-and-so has lived here for 5 years and he just got new hearing aids, but I swear he's having trouble remembering stuff. And then you go in and he doesn't have his hearing aids in, and you put him in and he's like sharper than I am most 90% of the time. Or you get the patients who had old dusty batteries that weren't working to power the hearing aids up, and they just needed a battery change. And so it's just always funny, because I know a lot of SLPs who wouldn't touch something like that with a 10-foot pole, but we're trained in, at least I was, and I went to school, you know, 100 years ago, but we were trained how to change batteries and how to look for earwax and cerumen, like clogging up different pieces of the hearing aid, and saying, you know, Mr. So-and-so, you probably need to go back and see your person that you got the hearing aids from, or go see your audiologist to make sure that these are cleaned up. I have cleaned them up a couple times myself, because it's really not that hard, but it's important. Just like maintaining function of any other piece of, you know, your glasses, for example. I clean my glasses all the time. So if they're not cleaned and they're not well maintained, guess what? We're not going to be at optimal vision. Just like for hearing, you're not going to be at optimal hearing if your hearing aids have no battery power and they're dirty.
Yeah, rechargeable batteries and hearing aids has been a game changer to take one frustration out of it, but there's still, I mean, our ears are dark, they're damp, they're almost 100 degrees because they're, you know, it's body temperature, and that and electronics don't work as well sometimes together, you know, so there are some things that happen, and wax is a big part of the issue. That's kind of why, these over-the-counter hearing aids, this category that came out a couple of years ago, we were all kind of upset and scared about what would happen when people could go down to Best Buy or order these hearing aids online themselves. But come to find out, the vast majority of patients do much better with professionals' guidance and expertise, like shocker. And most of it is related to like issues with wax and taking care of the devices and being taught how to do some basic troubleshooting at home.
Yeah.
There's not a whole lot to it, but I can see how it would be a little bit scary, whether it was for SLPs or, assisted living facility staff or, just the caregiver.
Yeah. And I think that's another a good important piece of holistic care is training the caregivers. For me, I would show the CNA, how easy it was to pop that little hearing aid battery out, pop it back in, and put it in their ear, and all of a sudden, the floodgates open, and Grandpa can hear me, and I'm right here. I'm right here. I'm
That
not
can be life
screaming.
changing,
Yeah.
life-changing for that particular person and for the caregiver, the family. I mean, it's pretty rewarding and fulfilling to watch it happen successfully, but
Mhm.
very frustrating when things go wrong.
So we have a question about Medicare, and does Medicare now cover hearing testing and as well as hearing aids?
So they'll cover the cost of a hearing test if there's medical necessity,
Yeah.
right? So we can't just randomly do a ton of like routine hearing tests and things like that. So there does have to be medical reason. And audiologists still need referrals if there's like some kind of acute change. So like dizziness or vertigo, a sudden hearing loss in one ear, the more acute changes. So they want a referral from, it doesn't have to be a physician. It can be many different healthcare providers, nurse practitioners and PAs, and I think even social workers and maybe SLPs, but I don't think you all are in that category. But they will cover hearing testing. They do not help at all with the cost of hearing aids. And then whatever Medicare denies, the Medicare supplements will typically deny. So most people who have a Medicare plan and a supplement still don't have any benefits for hearing aids. What is now becoming kind of a scam, I think this is my opinion, but for a lot of us, we're seeing hearing aids fit by these middleman, like third-party companies. There are many that are being advertised as part of the Medicare supplement plans. But when you dig in and read the fine print, they're providing discounts on, this made up like manufacturer, like an MSRP kind of price, and they're owned by hearing aid manufacturers and things that are somewhat shady. So you really have to be careful, but the official Medicare doesn't help at all with the cost of hearing aids.
Yeah. Well, and I think even with, like you said, SLPs, the route we would have to go for referral would be PCP or like an otolaryngologist or whoever maybe referred us to them in the first place would be, a lot of times I just go back to the PCP depending on who wrote the order for me, particularly if it's someone who maybe came from acute care and the ordering physician is the internal medicine doc who works at the hospital who's impossible to get a hold of. We'll go back and go through the PCP and just say, like in a progress note or in a request, say, hey, I've noticed and the spouse has reported or the caregiver reported a change in hearing, requesting a referral to an audiologist for further evaluation. So that would be the route we would take as SLPs, because it would be nice if we could just direct refer. That would cut a lot of time out for everyone involved.
I think we're pretty close to that. So there has been a lot more advocacy in the last 5 years especially, and hopefully that day will come fairly soon.
Yeah, we did have a comment from Sylvia. This is so important. I had to train several of my mom's CNAs when she was in assisted living. They didn't automatically check that she was wearing her aids, and then they were turned on. When they were turned on, it was hard to get someone to take responsibility for checking batteries periodically. I ended up checking the batteries most of the time. Yeah, and that's definitely what I saw. And the problem with having, put the burden on, I don't say when I say burden, what I mean is putting the burden on family who may be long distance caregiving. They may not be immediately geographically there. And so it's hard for them to take on the responsibility of the maintenance of the hearing aid when they're physically not accessible.
I will say that's also another added benefit to rechargeable hearing aids at this point, because they will turn off and start charging when they're placed in the charger, and when they're pulled off of the charger, they will automatically turn themselves on. So, there's, if they've been placed on the charger properly, which is pretty straightforward and pretty difficult to mess up, it's really nice that they don't have to, like close the battery door and change that battery and make sure the battery is still going. And if they fall asleep with them on, that's not going to cause any major issues. You can't overcharge hearing aids or like mess them up really nowadays with these rechargeable batteries. So we've really come a long way.
Yeah, I had just two patients when I was still working an outpatient who they called them, the one guy called them the newfangled, the newfangled hearing aids, where you just plug them into the charger. And he'd been wearing hearing aids for quite a while because he'd worked in construction as a tile installer. And so there was a lot of noise where he worked. So he'd been wearing hearing aids for probably 20 years. So for him, that was like a game changer. And he was just so excited about it. It's like the first thing he said during the evaluation, that we were there for something completely different, like cognitive stuff. And he's like, this was a game changer for me, which is cool.
You could do a whole nother podcast about hearing aid technology at this point, because it has come a long way, and Bluetooth and direct audio from cell phones and geotagging locations and find my hearing aid features, like there's all kinds of stuff. Fall alert and fall detection. There's hearing aids that track like social engagement and conversation, how much people are talking with other people. And you've got all that stored in the computer chips of these hearing aids that you can document and reference. It's pretty amazing.
That would be really super cool research.
Joni,
to see what see the social engagement is and how much social interaction people are getting. I would love to see that.
And that's what the hearing aid manufacturers are kind of playing to Medicare. Like we have all these tracking milestones, and you want to talk about like evidence-based care and outcomes that can be measured and tracked, like you've got a computer in each ear. I mean, one hearing aid can run my desktop computer or your iPhone. Like it's all there, and you can take a deep dive, talk about like big data and AI learning and everything. Like you can take all that to a health insurance company and say, look at all these falls that we've tracked and how when the hearing aids are working properly, the fall reduction is dramatic. Like it's all there, and it's coming very soon.
That's so cool.
So we're not there yet, Joni, but we're getting closer and closer
to Medicare covering hearing aids.
Hopefully,
Yeah. So, and I think because you and I worked together, I was coming off the board when you were coming on to the board for the state, and thinking about just advocacy efforts for that. What are some things that people can kind of do maybe at their state level or their community level to make that more of I'm talking about professionals like SLPs and audiologists, to kind of bring that to the forefront more? So will it be like community education or advocating within their own No, not necessarily, I guess private practice too, but like within the health system, are those good avenues to kind of explore for coverage?
Yeah, I think even sending an email or, like we went to the state capitol for Martin Luther King, like Advocacy Day. And all of those elected officials, it didn't have to be like a congressperson, it could be a staffer, but they're like, wow, thank you for coming and talking about this because we had no idea this was a thing and we really didn't know what you all did. And this sounds amazing. We're firing off an email to kind of vent your frustrations. I mean, like that could be sent to a state official, someone who's in your district to say, like, these are my challenges every day. I think
Mhm.
most people want to help, they just don't know. And once you point out a topic and you're passionate about something, like that shines through and
Mhm.
they're willing to help. They just don't know. Uh,
Yeah,
and like all the community outreach and things makes a big difference too. Every little bit helps. Getting involved in the state associations that you're with, in my opinion, is one of the best things you can do because so much happens at the state level, which
yeah.
I mean, I knew, but like you don't really know until you volunteer, and it's like, wow, this is a
Yeah,
lot. We're all volunteers, and like the needle moves so slowly, but yet it moves, and like you're making progress, and you have some wins, and it feels good to help out.
yeah. No, I agree with you. We do have another question. Dr. Cook, do you find some people have a difference in hearing problems between male and female voices? And the second part of that is, can the aids be programmed for different frequency voices?
Yeah, definitely. So most age-related hearing loss hits the higher pitches first, which is where female voices are and younger kids. So most people, I say most, but I mean, this is like general, typical kind of hearing loss. As people get older, most people hear the men's voices and the background noise, anything with a lot of bass, they can hear better than the higher pitches. And then, yes, the hearing aids are programmed. Basically, the hearing test is flipped upside down. And so the hearing aid is programmed to that patient's specific hearing loss. And they may not need a lot of lower pitch bass tones and volume, but they definitely need the audibility and the higher pitches for the clarity and the voices to pop better over the background noise. Like most consonants are higher pitch, and that's why people can hear, but they can't really understand. We take it also a step further at our office. There's testing that can be done with tiny tubes in patients' ears, and then the hearing aids are placed over top of those tubes, and we can actually measure what's happening in someone's ear canal with the hearing aids in. And so you can start with the hearing aids program to that patient's hearing test, and then optimize it even more specifically to exactly, like, you can document what's happening and make very precise changes to really make the sound quality customized to what they need.
That is really cool.
Yeah, that's real ear measurements or live speech mapping that's done. And everyone is a little bit different. So that's also been a game changer when it comes to hearing aid programming.
Yeah. Well, and we also have another question that says, can hearing aids actually normalize speech understanding in noisy conditions?
I would say hearing aids keep getting better and better at that. So that digital computer chip is constantly analyzing what's coming in, and we're talking about like millions of times a second, and analyzing if it's something quick that comes and goes like speech or music, that gets prioritized and amplified. And then if it's steady, like background noise or speech babble, the HVAC system or the fridge cutting on and off, it says, oh, that's steady and it's not changing. And so I'm going to kind of lock onto that and pull it down. And so the voices and the quicker sounds get brought up, background noise kind of gets pulled down. And so you get the audibility and the access to sound without necessarily hearing all the background noise. I mean, you hear it, but it's not as loud as it could be.
No, I was going to say, I wonder if that's what Zoom did. And I'm not being disrespectful when I say that, but like when we first started using Zoom as an organization, we heard everything. It was like, you know, thunder, or my ice machine just dropped in the refrigerator, and you could hear that. And now you really can't. So when we go back and listen to the recordings on Zoom, you don't get that background noise. So I wonder if that's the same technology that they just knew they had, so they employed it, because it makes perfect sense.
Yeah, I mean, all the digital technology, that kind of stuff has come a long way. I would say more expensive hearing aids are better with all of that. You know, there's a more sophisticated, more powerful computer chip that's analyzing in a more sophisticated way compared to hearing aids that are less expensive. And we're talking about like true prescription hearing aids that are fit by audiologists. Like that's what makes up these kind of, what most people would say are these crazy differences in what hearing aids cost. Better, more expensive hearing aids do all of that in a more sophisticated way.
Wow, that's really cool.
So someone with like cognitive decline and would need more support, helping sort voices through the background noise. Like, so we can tie this together and like summarize, you know, like those people who have more struggles in noise or with cognitive load, they need more support. And so better hearing aids would be recommended to make the voices pop better over the background noise, and like all the best practices and all the things that could give that patient better outcomes compared to someone who doesn't have the same kind of struggles and they've got more brain power to do what they need to do. And like some people are very good at that and some people need more support.
My mind is kind of spinning about this technology. It's really, really cool. So if I go quiet, it's because I'm thinking. Then we do have one last question before we wrap up. My husband had a stroke 2 years ago, and he doesn't seem to be hearing as well. He does have hearing aids, but won't wear them. Any suggestions? You mean suggestions to get him to wear them?
I would, ask him more about why he doesn't wear them, what he would want to change or improve. You can only do so much. Like he has to mentally be ready and willing to wear them. But at this point, you two have spent the money for hearing aids. He has them, so hopefully there are things that can be done, like that real ear measurement testing or something else that could be changed to make him more likely to wear them. But that's a tough one. There may be something related to like frustrations and background noise or something that did change cognitively that, like maybe he's overwhelmed and needs more support or something like that. Yeah, it's sometimes tough, but tell him if he can tough it out, it'll be worth it in the long run.
Well, thank you so much, Dr. Cook, for joining us. I just appreciate you coming on, and I actually learned a lot myself. So I appreciate you being willing to do this and to share your knowledge with us. It's particularly about the hearing aid technology. I think that was probably my favorite part, just because it's just unique and different from what I do on the day-to-day. And thank you again, Dr. Cook, for being here, and we look forward to seeing you again.
Yeah, feel free to share my email address. And if anyone has any questions, I'm happy to talk offline and things, anything I can do to help.
Thank you. I appreciate you.
Take care.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use Brainstorms20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms, Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.